Good morning and welcome everyone. Appreciate everybody joining us nice and early. My name is Ananth Shenoy. I am an internal medicine physician and one of the members of the Washington chapter of ACP and our current treasurer. And I have the privilege to introduce our first speakers. We are very fortunate to have Dr. Thomason and Dr. Bays, who are joining us from the University of Washington, who will be speaking to us on rheumatology topics that are pertinent to the boards. Just as a reminder, of course, everybody was able to find the course website. And obviously, we got the link for this. And the website at the end of each day or by early the next day will have the slides of the respective speakers that will be up. There are also a number of pre-recorded talks because we don't have time during the course of this course to cover all the content that we would like to. So I would direct everyone else, while you're doing your independent study, you'll be able to check out the pre-recorded lectures. Also, later this week, all of these talks will also, the recordings will also be posted to the website, and there'll be links to it in addition, of course, to the slides themselves, as I mentioned. We'll also remind you Friday after the course, if you can fill out a course eval, that is very helpful to us in planning our speakers for next year and making sure that we are covering things in a way that is helpful to you as you study and prep for the boards. So without further ado, I will turn it over to Dr. Thomason to take it away and start us on our voyage through rheumatology topics.
Okay, great. Thank you so much. I'm Jenna Thompson. I'm an assistant professor at the University of Washington, and I'm going to go through several topics, and then Dr. Bays is going to take the second half of our time. I'm going to spend a little time talking about sorting out arthritis and time and space. Common causes of musculoskeletal pain, I'll go through fairly quickly so we can get to some of the more complex topics like systemic lupus. We'll touch on axial spondyloarthritis, osteoarthritis, rash and arthritis, and myositis. So, sorting out synovitis. So, this is one of the sort of key things that we try to impress upon all of our learners when they come through is trying to differentiate the patterns of joint pain, inflammatory, mechanical, or more of a central pain. And inflammatory arthritis in general is pain that is worse first thing in the morning, generally associated with prolonged stiffness, usually an hour, and improvement with activity, often in association with swelling. Whereas mechanical pain usually is best first thing in the morning. People might have some stiffness, maybe up to 15 minutes of stiffness. We call that this gelling phenomenon. Every once in a while, someone will have stiffness that lasts maybe a little bit longer. And then in general, worsening with activity. Whereas fibromyalgia or central pain tends to be more widespread, harder to localize specific areas that are hurting more than others and associated with other symptoms, including severe fatigue, particularly post-exertional fatigue, and this feeling of if I overdo it, I pay for it. And that type of pain generally is both in muscles and joints. Um, so this is a figure that really has helped me over time, also with explaining this to learners. So again, sorting out arthritis in space and time. So when you have a patient that comes in with arthritis, you can think, is this inflammatory? Is this mechanical? And then you also want to think, how many joints are affected? Is this someone that's coming in with one inflamed joint, um, polyarthritis or oligoarthritis, which is 2 to 4 joints, or a polyarthritis, which is 5 or more joints? And each one of these things, and also, uh-oh, my screen just disappeared. Oh, shoot. All right. Also, you want to think about the chronicity, whether it's something that's happening acutely or something that is kind of more chronic over time. An acute monoarthritis, we're going to talk about this on the next slide, is has a very limited differential. And then acute inflammatory arthritis affecting more joints, we think about potentially a reactive arthritis. As you see, this can span all three of these sections, monopossy or polyarticular arthritis. And then other acute and polyarthritis syndromes include disseminated gonococcal arthritis, serum sickness, viral arthritis, and then chronic arthritis has its differential as well. Also, we think about the location of the pain. So if, say, someone comes in with hand pain, They are probably, talking to you about in general about having pain in their hand, but asking them specifically, like, where are you feeling the pain? Like, is it in the wrist? Is it in the radial side of the wrist? Is it at the base of the thumb? If localizing it very specifically will help us sort of narrow down what we're thinking about. So, chronicity, number of joints, location of the joints involved, or is the patient someone that's coming in with perhaps more tendinous disease? So, this is a famous figure from Nature Rheumatology. And it's a beautiful figure just to look at and to understand and also to show patients. So this is a normal joint. As you know, the bones come together. We have cartilage. We have this synovial lining that kind of lines the joints. And then around the joints, we have ligaments and tendons. So synovitis, which we classically see in, say, rheumatoid arthritis, is inflammation of the synovium, and those are the patients that come in like with a generally warm, like frankly swollen joint. But then there are other patients that may present more with what we call enthesitis. So patients that have spondyloarthritis syndromes, including axial spondyloarthritis, reactive arthritis, psoriatic arthritis, inflammatory bowel disease related arthritis, those patients frequently have enthesitis. And enthesitis is inflammation where the tendon inserts into the bone. And these folks, like you may not see their inflammatory arthritis as easily as somebody that has frank synovitis, like rheumatoid arthritis. And it can be just as painful and just as debilitating. Often these folks will say, like, I have pain like around the joint. Here, there's pictured classic Achilles enthesitis. So somebody that has, say, psoriatic arthritis or axial spondyloarthritis classically will have pain where this tendon is inserting into the calcanea. So it's very low, as you can see on the Achilles tendon. Also, plantar fasciitis is common, epicondylitis. And then when we think about axial spondyloarthritis and bamboo spine, what that is actually like a lot of enthesitis in the spine. So, thinking about arthritis in time and space. And I mentioned, like, when someone comes in with an acute monoarthritis, we have a fairly short differential for that. We like to call that a BBC joint. And the reason for that is it helps us remember that an acute inflammatory monoarthritis, a joint that is so painful that the patient says, like, do not touch my joint, do not move my joint, we think of bugs, blood, and crystals, BBC. So bugs refers to bacterial arthritis. You could have, say, like someone with a fungal arthritis or TB arthritis. Those generally are kind of like slow over time and not so acutely severely painful. We're generally talking about like a staph arthritis or strep or gonococcal arthritis. The patient says, like, do not move my joint. It is so painful. Um, Blood in the joint can happen for a number of reasons, like frequently trauma or anticoagulant use with minor trauma or a patient with hemophilia. Blood is very irritating in spaces where it's not supposed to be, as you know, and it is very painful. And it feels hot too. And then also crystals, which Dr. Bays is going to talk more about, the acute gout or pseudo gout, is also acute CPPD or calcium pyrophosphate deposition disease. So, some common musculoskeletal issues that will show up on the board. So, here's our first poll. So, 55-year-old right-handed man complains of right shoulder pain for a month. He has pain with reaching for his wallet and overhead activities. He has pain when he sleeps on that side. Ding, 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 that's important. It began after painting his house, no paresthesia or radiation of the pain. He has pain on active abduction between 60 and 120 degrees, and pain on resisted right arm abduction with no obvious weakness on abduction or external internal rotation, and no atrophy of the shoulder girdle musculature. The most likely cause of this patient's symptoms is it biceps tendonitis, AC arthritis, rotator cuff tendinopathy, or glenohumeral arthritis? Okay, cool. Nice. All right. Sharing results. How do I get out of here? Okay. Oh, shoot. Sorry. All right, good work, guys. So yes, rotator cuff tendinopathy. Okay, so the shoulder, this is the differential diagnosis of shoulder problem. So, um, thinking about the shoulder can be complicated. The key there was, he had pain after activities like working above his hand. He had pain with laying on the shoulder at night. That's one of the most common things that I hear people say on history when they have rotator cuff tendonitis. And then on exam, he had essentially a positive ARC test, confirming or sort of making it likely that he has some rotator cuff tendonitis. If somebody came in with severe shoulder stiffness, that was fairly acute, particularly like an older person, someone older than 50, along with hip girdle stiffness in the morning, you might think about polymyalgia rheumatica. If they have like very limited range of motion of the shoulder, particularly in the setting of diabetes, think about adhesive capsulitis. Also, glenohumeral osteoarthritis, so your shoulder x-ray will be really helpful. If they are someone that's coming in with weakness of generally both shoulders, both hips, without a lot of pain, think about myositis. If it is weakness with radiating pain down the arm, think about cervical radiculopathy. And then pain with movement, rotator cuff pathology, as our patient had, and then AC arthritis. If they have pain with this cross arm testing where they reach across and they compress that AC joint, think about AC joint arthritis. Um, so this I'm going to leave for you all to review later, um, talking about rotator cuff tendonitis. And so the second case, 72-year-old woman was working in the yard, heard a pop, and her arm looks like this. She's a Popeye muscle. What's the most common underlying cause of this finding? Is it proximal long head of biceps rupture, proximal short head of the biceps rupture, subscapularis tendon rupture, or supraspinatus tendon rupture? All right, you guys are doing great. 60% got the right answer. Okay. So, all right. And then, so that was, sorry, long head of the biceps rupture. 59-year-old man with progressive pain with the use of the right shoulder comes to clinic. He has difficulty washing his hair, reaching for his wallet, and these motions are painful. There's decreased range of motion at the shoulder with pain throughout the limited range. He has mild atrophy present about the shoulder and feeling creaking with range of motion. What do you want to do for this guy? Do you want to get a CT scan, MRI, shoulder ultrasound, or start with an x-ray? All right, crushing it. Okay. I would too. I would start with an x-ray, right? Like it's quick, easy, available, doesn't require any sort of pre-authorization, and it will give you the answer in this situation because this person has osteoarthritis of the shoulder. Again, I'm going to leave this for you all to review later, especially because you all crushed that question. So this patient has pain in the wrist after a fall and an outstretched hand with tenderness in the snuff box. An important sequelae of this injury is it scaphoid osteonecrosis, radial nerve injury, arthritis of the CMC joint, or ulnar artery injury. And this is fall on an outstretched hand. Foosh, like fall on outstretched hand. Nice. Again, you guys are totally crushing it. So yes, scaphoid osteonecrosis. And this is important because it's really important to know because this is something that can happen and you may not see it initially. Like if you get an x-ray acutely, you may not see anything on the x-ray, but if you wait about 2 weeks and repeat the x-ray, that's when you're going to see it. And it has to do with the blood supply to the scaphoid is a bit unusual. It's a retrograde blood supply. So you can fall in the outstretched hand, disrupt the blood supply, not see anything initially, but then 2 weeks, once this pathology has had time to progress, then you will see it on an x-ray. All right. Um, 55-year-old woman complains of 1 week of pain in the base of her thumb. She'd been trimming her roses prior to the onset of the discomfort. She's noted that there's some swelling along the distal radius and pain with ulnar deviation of the wrist. The most useful initial diagnostic test would be an EMG, nerve conduction study, X-ray of the hand and wrist, musculoskeletal ultrasound, or Finkelstein test. All right, you guys are really know this stuff. It is the Finkelstein maneuver because um, at the Finkelstein maneuver, actually, this patient has decurvence tenosynovitis, which is inflammation of the EBP and APL, the tendons here. So when you do the Finkelstein, you have the patient close their hand over their thumb and essentially stretch those tendons. And if they have decrevence tenosynovitis, they will jump off the table. It is very, very painful when they stretch those tendons. That would be a positive test for decrevence tenosynovitis. Um, this one I'm gonna skip um, through. This one I'm gonna leave for you guys as well. Um, this patient the has okay, the most likely cause of swelling in this patient with rheumatoid arthritis and 2 weeks of knee pain is this is a gastroc muscle rupture, venous thrombosis, Baker cyst, or calf hematoma. All right, good. We got finally got a little more spread on the questions. Okay, good. Um, so this is a Baker cyst. So yes, this patient has rheumatoid arthritis, but as you know, our patients with rheumatoid arthritis, they also get osteoarthritis. They get secondary osteoarthritis. And Baker cyst is something that can commonly form in the setting of arthritis. And often that knee, it collects in the back of the knee, but at times it can rupture. So if you see a patient that has, knee osteoarthritis, perhaps they have a known Baker cyst, and suddenly they have fluid in the back of their leg, frequently that can be due to a ruptured Baker cyst. You can treat it before it gets to that point. Consider inarticular steroid injection. Folks that are adept at ultrasound can aspirate and inject the knees for that patient, which can increase comfort. Plantar fasciitis is strain of the plantar fascia as it inserts into the medial calcaneus. This is a very, very common and it can be an inflammatory or a mechanical phenomenon. We see this frequently with patients with psoriatic arthritis, axial spondyloarthritis, or other spondyloarthropathies. This one is a question about Achilles rupture. And the answer to this one is the Thompson test, which is the squeeze of the calf muscle, which is going to give you an indication of whether the tendon is intact. Because when you squeeze that calf muscle, the foot should plantar flex if the tendon is intact. These are, of course, terrible injuries. Achilles tendon rupture in particular requires surgery and generally a long recovery time. So I'm going to move on to talking about systemic lupus. So um, this is, obviously much more complicated talk and hard to squeeze into a short period of time, but I'll try to impress upon you some pearls. So when we are thinking about lupus or any of the ANA related diseases, we we generally want to send an ANA test, right? We're all familiar with the ANA. But an important thing I want to impress upon you is sending both the ANA immunofluorescence. That's the one that gives you the titer and pattern, right? That we're used to seeing like 1 to 80 homogeneous or 1 to 320 speckled or so on and so forth. So we want both the immunofluorescence and the multiplex or ENA panel. The ENA panel is the one that has all of those specific autoantibodies. So the anti-Smith, Smith RNP, RNP, anti-chromatin, SSA, SSB, centromere, all of those antibodies. The reason for this is that each one of these parts of the test has a specific role. The ANA immunofluorescence, which gives the titer and pattern, is the sensitive part of the test. That is like the part that is going to include everybody and more. That's where you're going to see a lot of false positives, right? Because based on studies that have been done, we know that in the general population, maybe like 13% of the population has an ANA of up to 1 to 80. So that's going to, include more false positives. The ENA or multiplex panel is what confers specificity to the test. So that is what helps us figure out how significant that positive ANA immunofluorescence is and helps us define a clinical syndrome for patients. When we're thinking about lupus specifically, the anti-Smith antibody is very specific for systemic lupus. Also, the ribosomal P antibody is also very specific and also has an association with neuropsychiatric lupus. The double-stranded DNA is a very special antibody because, in general, when we talk about antibodies in lupus, they are kind of black and white. They're either positive or negative. Double-stranded DNA is very special because it can go up and down with lupus activity, particularly nephritis. So the double-stranded DNA is going to be useful for both diagnosis and also for monitoring disease activity over time. So double-stranded DNA is a very special antibody. The sensitivity and specificity, it really varies depending on labs, and there's a bigger story behind that that I won't talk about. So having, your neighborhood rheumatologist help you interpret the meaning of a double-stranded DNA can be really helpful. RNP is a common antibody. It is, it can be seen in lupus, but it's also associated with other conditions, particularly mixed connective tissue disease, which is an overlapping condition of lupus, myositis, systemic sclerosis, and rheumatoid arthritis, really. The SSA antibody, I always kind of joke about it as being like the most like sort of promiscuous of all the antibodies. It can be seen with any ANA related autoimmune disease. When you see it in isolation though, or in combination with a anti-SSB antibody, we think about Sjogren's when we're thinking about systemic disease. It can also be seen with subacute cutaneous lupus. And it's also important in mothers who have an SSA antibody, which we'll talk about in a little bit later. So again, this is just explaining what we're talking about, the immunofluorescence being the sensitive part of the test, and then the ANA multiplex or ENA panel being the sort of specific part of the test that helps you define a clinical syndrome. In 2019, the EULAR, which is the European League Against Rheumatism, and the ACR, American College of Rheumatology, got together and they gave us new classification criteria for lupus. And this is something that is used for defining or helping sort of identify patients for inclusion in research studies. And so they're not diagnostic criteria, but they sure are helpful in thinking through whether somebody has lupus or not. So they can be, so helpful for thinking through these patients who are very complex and generally have many different symptoms across many different organ systems. So this criteria, they have an entry point of an ANA immunofluorescence of greater than 1 to 80. Remember, that's the sensitive part of the test. That's what gets people in the door is that ANA immunofluorescence. And then what you do once you're in the door is you go through each of these criteria, including constitutional symptoms, cutaneous, arthritis, neurologic, and so on. And these can be things that have happened really at any time in this patient's life. They don't have to all be happening at one time. You can't say you have a patient that has non-scarring alopecia, oral ulcers, cutaneous lupus, and acute cutaneous lupus, you can't include all of these points. You would just include whatever sign or symptom in that category gives you the most points for that specific category. And then once you accumulate a total of 10 or more, then the classification criteria for SLE is fulfilled, and you can include that person in research studies. But again, we're talking about how helpful this is for diagnosis because lupus, as you know, it's a very heterogeneous disease. People have so many different symptoms, and frequently those symptoms are fairly non-specific. So you'll see like number one up here, 85% of patients have arthralgia, which it can be fairly non-specific or constitutional symptoms. And so, thinking about all the pieces, putting all the pieces together, that lab criteria, exam, and the patient's history and clinical symptoms is what helps you get to the diagnosis. These are some images in lupus. This is a patient with horrible acute cutaneous lupus. You notice the classic sparing of the nasolabial folds. We don't know why that happens. Maybe from relative shading from the sun. This is a patient that looks like they have scarring alopecia. Um, this is another image of acute cutaneous lupus. Classically spares the PIP joints, which is the opposite of dermatomyositis, which likes to occur over the PIPs and MCPs, occasionally DIPs. And this is a patient that has something called Jacquard's arthropathy, where they have hyperextension at this joint and flexion at the distal joints, but it's completely reversible if you put the patient's hand down on the table. Okay, all right. Deep breath. 27-year-old woman is establishing care for a recent diagnosis of systemic lupus erythematosus. Her symptoms include arthralgia, malar rash, pericarditis, and thrombocytopenia. She's on prednisone 20 milligrams daily, and her symptoms resolved after 1 week. Her exam is normal, other than tenderness at her PIP joints. Her CBC is normal, other than platelets of 97,000. Her complete metabolic panel is normal. She's ANA positive, with positive anti-Smith antibody, low complements, and anti-cardiolipin IgM and IgG. Her C3 and C4 are both low. Her urinalysis is without protein or blood, thank goodness. Which of the following is the most appropriate management? Do you want to put this person on hydroxychloroquine? Do you want to increase prednisone? Do you want to start mycophenolate? Do you want to start etanercept? Wow, I'm so happy with these results. I'm so happy. You guys are awesome. Okay, we gotta make these questions harder. 100%. Wow, good work, team. Okay, so start hydroxychloroquine. And indeed, and I'm so happy that you guys know that hydroxychloroquine is the most important therapy for our systemic lupus patients. It is the one therapy that every patient with lupus gets. And over time, the more and more data has accumulated about how hydroxychloroquine has a mortality benefit in lupus. So patients that are on hydroxychloroquine, they live longer. They also it can lower lipids. It helps in mothers with SSA antibodies who are pregnant to prevent neonatal lupus. It can help mycophenolate work better in renal lupus. It is just so important. And as you know, I tell patients like this is the safest medicine that we prescribe in all of rheumatology. There is potentially this risk of retinal toxicity, which is a long-term risk. So patients generally will get eye screening over time. And this is a very busy slide, but what I'll say about this is that we have had a dearth of medications for systemic lupus for many years, but in the past few years, we've had multiple new approvals. Starting with anifrolumab was approved in 2021. This is an absolutely incredible medicine particularly for skin, lupus in the skin. Belimumab, which was approved in 2011, got approval for lupus nephritis in 2020 after proving benefit in lupus nephritis. Voclosporin is a calcineurin inhibitor, so a cousin of tacrolimus that doesn't require lab monitoring, which is great. Approval in 2021. Obinutuzumab was just approved last year. It's a cousin of rituximab, but leads to much deeper B cell depletion in tissue. And then as you may have heard, we are deep into the CAR T trials for systemic lupus, which are just like absolutely incredible and showing really amazing results. I was explaining it to one of my patients who works in tech, and what he said back to me was like, so essentially, you're turning the immune system off and turning it back on. And I was like, that's such a great explanation because that's really what it is. We take the patient's T cells, lower their immune system, weaponize these T cells against their B cells, give it back to the patient, and then it goes in and just essentially reboots the immune system. And this is still in the trial phase, but just so exciting and like the sort of best hope we've ever had of curing systemic lupus. So you've diagnosed your patient with lupus. How do you know if your lupus is active? So I will tell you that there's never really just one thing that determines if your patient's lupus is active. We are always thinking about clinical symptoms, exam, and labs, and wrapping all those things together to determine the activity of the systemic lupus. Because you're not going to just see one thing. You're not going to see a patient coming in with skin vasculitis without any immunologic activity if it's related to lupus. It's going to kind of go together. And remember that magical anti-double-stranded DNA antibody that we were talking about? That is the one that goes up with activity, and not for every lupus patient, but commonly, and it could be so useful. And you'll notice when these patients are seen in room clinic, they get it checked every time, whether they're active or not. The reason for that is we look at the increase and decrease over time. So there's not like a relative cutoff, like, greater than 100 means you're active. It's different for every single patient, and we monitor over time. Same thing for C3 and C4. We check it every time because we look for the increase and decrease over time to help determine activity of the disease. All right. Very quickly, lupus nephritis, one of the very common and most feared complications of systemic lupus is lupus in the kidney. And when you suspect this, generally when patients they will have proteinuria. Generally, that's the one that we see most common with any type of active lupus nephritis. If they have class 3 or 3, 4, you might see hematuria and dysmorphic red blood cells. If you were to look under the microscope, dysmorphic red blood cells means that they're abnormally shaped. They kind of look like Mickey Mouse. And the reason for that is those red blood cells are being squeezed through an inflamed kidney before they come out in the urine. And that can be a clue that the patient has lupus in the kidney. So there's actually 6 classes of lupus nephritis, and I think this classification is wonderful, but also kind of confusing because when you say to a patient, you have, class whatever, they sort of like relate that to like cancer stages. But actually, the worst type of lupus nephritis that you can have is actually class 4. So this type of lupus nephritis is means that your kidney is very inflamed and that it involves greater than 50% of your glomeruli. These are the patients that are at risk of sort of rapid deterioration and renal failure. These are the patients that we are admitting to the hospital, giving them IV steroids. We're treating them most aggressively. The class 3 or focal lupus nephritis is kind of like the maybe like earlier or lesser stage of that, where there is inflammation, but it's involving less than 50% of the glomeruli. We still treat these patients aggressively because they are at risk for progression to more severe disease. Class 5 nephritis is kind of like a different flavor altogether. This is membranous nephritis. And these are the patients that present primarily with proteinuria. So they may not have any hematuria or pyuria in their urine. They might just have a lot of protein. And it's serious, but it's generally treated less aggressively than class 3 or 4. Class 1 and 2, those are fairly minor, and those we just have people on hydroxychloroquine, and they generally will do well as long as they are adherent to their medication. Class 6 basically means that the kidney is severely damaged. Sorry, this is a little bit blurry. So, and this is obviously very busy. So in 2024, the ACR gave us new lupus nephritis guidelines, which are like absolutely wonderful and really just reflect the past few years, the work that has been done in this area. And I will say, like, as you guys know, number one, everybody gets hydroxychloroquine. Everybody with lupus nephritis gets hydroxychloroquine. And apart from that, the specific treatment really depends on the class of lupus nephritis and also like how aggressive it is. So if it's a very aggressive, we're going to give them pulse IV steroids followed by early combination therapy. This is the change with the 2024 guidelines. We used to just give people mycophenolate, just give them cyclophosphamide. Now, up front, we are giving them combination therapy. So everybody gets steroids, and then they will get a combination of mycophenolate and belimumab, or mycophenolate and a calcineurin inhibitor like tacrolimus or voclosporin, or they'll get cyclophosphamide with belimumab, and that's for aggressive disease. And we choose those therapies kind of based on what we see in the biopsy, what's happening in the rest of the patient's body. And another change in the guidelines, more recent guidelines, is that like we are really trying to taper people off of steroids faster than we used to. We used to leave people on steroids for a really long time. And now we're just like, we finally have more therapy to give patients. And we recognize the damage that leaving people on steroids causes. And so we are trying to taper them to 5 milligrams or less by 6 months and ultimately off of steroids. Okay, so another question. 53-year-old man, he has plaques on his face and neck and ears, a little bit of scale, biopsied and found to be consistent with discoid lupus. The highest risk factor for this patient to progress to systemic lupus is, so this guy, he doesn't have systemic lupus, but he's got discoid lupus. Okay, good. Finally, we got one with some spread here. Okay, good. All right. So the answer is a positive A and A. So plenty of patients, in fact, most patients with discoid lupus, they don't have systemic lupus. Generally, discoid lupus without systemic lupus is isolated to the head and neck. If it's happening on other parts of the body, they are more likely to have systemic lupus, or if they have a positive ANA, that is associated with progression to systemic lupus. All right. If a child with a rash is born to a mother with lupus, which antibody is the mom likely to have? And spoiler alert, I said this earlier. All right. Okay. Good work, team. An anti-SSA antibody. So, ethylene pregnancy, we tell patients, and it doesn't always work out this way, but like the ideal situation is that the patient will be in, like well-controlled lupus for at least 6 months on a regimen that is compatible with pregnancy, which of course all of our medicines are not compatible with pregnancy. Mycophenolate in particular is very teratogenic. Hydroxychloroquine is compatible with pregnancy. We often will transition patients to azathioprine if they need to be on a classic DMARD. Prednisone, ideally the patient will not be on prednisone, but it can be given. It is associated with birth defects, particularly when used at higher doses earlier in pregnancy. And then the latest guidelines from the European League Against Rheumatism really liberalized use of biologics in pregnancy. And there's good safety data for some of them. Some of them they say, like, we're still working it out, but it's looking positive. And if you have to use it, you can use it. So we're getting more tools for taking care of our patients. And very important for lupus patients to be on aspirin for preeclampsia prevention. Patients that have SSA and SSB antibodies, and this is not just patients with lupus with these antibodies, patients with Sjogren's, or patients that just have these antibodies in general without systemic autoimmune disease, their babies are at risk of developing neonatal lupus, and this happens due to passage of the anti-SSA and SSB antibodies across the placenta. So these patients will get they should see a high risk OB. They should get special monitoring during pregnancy, usually with ultrasound or the fetal heart Doppler throughout ultrasound. And this is an evolving field right now. Also, we want to think about antiphospholipid antibodies. in patients who are pregnant. That might affect how we sort of manage anticoagulation during pregnancy and for the weeks after pregnancy. And also, if you are needing to talk to your patients about contraception, the ACR reproductive guidelines from 2020, I think, 2020, they have like a beautiful chart that outlines like which contraceptives are safe in women with rheumatic disease, and in particular safe for women with lupus, because there are a lot of messages there about safety, in particular patients with antiphospholipid antibodies, or say they have active lupus. There might be some options that are not available to them, but in general, IUDs are safe in all of our patients, or implantable birth control, or progesterone only pills. Drug-induced lupus. What I really want to get across about this is that there are a lot of drugs here. The kind of classic ones that you think about are hydralazine. Also, TNF inhibitors can induce systemic lupus. And these are the patients that actually get an anti-double-stranded DNA antibody when they have drug-induced lupus. We often think about antihistone antibodies as being associated with drug-induced lupus. That is true. Antihistone antibodies can also be seen in regular lupus, so we have to carefully interpret them. But if you are seeing a patient who doesn't fit the usual demographics for lupus, so say it's someone that's older, particularly a male who has fairly sudden onset of symptoms, think in your mind, like, could this be a drug-induced form of systemic lupus? And drug-induced lupus gets better when you stop the drug. All right. So we have a 22-year-old male who complains of 3 weeks of low back pain, especially at night and early morning. He feels better during the day, and especially when he is active. Vital signs are normal. He's afebrile. His general exam is normal. He has a positive Patrick maneuver on both sides. Schober is normal. Hyperextension of the lumbar spine causes pain. He's got such mild anemia, mildly elevated ESR. And you got a film, radiograph of the pelvis, which shows erosions at the SI joints. So what do you want to do for this patient? Do you want to start him on an NSAID? Do you want to check HLB27? Get a CT scan of the SI joints or an MRI scan of the SI joints? All right, nice spread here. Okay, good. So I would say like actually like any of these things could be could be useful. The thing that I want to do first for this patient, like right off the bat to help him feel better is start him on NSAIDs. So NSAIDs, this patient has axial spondyloarthritis. We call also called ankylosing spondylitis. The first thing I want to do is like try to help him feel better. You can check an HLA-B27. It's a genetic test that is associated with axial spondyloarthritis. It's not really going to help you here because you have a patient that is a classic demographic, classic symptoms with a radiograph that is showing you that this patient has sacroiliitis. CT scan that will give you more information about the architecture of the bones, show erosions. An MRI is good for detecting like earlier disease. It can show you bone marrow edema, not particularly necessary here, right? Like you've already have enough information to diagnose this patient. So axial spondyloarthritis, these patients, they generally are young patients. Historically, we thought of them as being primarily men, but now we know that like, plenty of women get this too. It's maybe like even 50-50. Um, it generally affects the sacroiliac joints, the lowest part of the spine. People will talk about having like buttock pain or alternating buttock pain, and it's inflammatory pain. So worst first thing in the morning often like gets them out of bed. Like have to get up at 4:30 and go like walk around and move because they feel better with movement. They may have that enthesitis that we're talking about. Remember where the tendon inserts into the bone, that area of inflammation, or dactylitis, which is like a sausage digit or toe. That's essentially a lot of enthesitis along the finger or the toe. Acute anterior uveitis is common with axial spondyloarthritis. So an acute and severely painful inflamed eye. Super rarely some problems with the aorta, like aortitis. So again, this is that same figure that we saw in the very beginning, but just a reminder that these are the folks, axial spondyloarthritis, psoriatic arthritis, inflammatory bowel disease arthritis, reactive arthritis, patients that can have that inflammation where the tendon insertions of the bone, that type of inflammation that can be harder to pick up. But if you press on their entheses, you press at their sort of distal Achilles or plantar fascia, press it around the knees, often you will be able to differentiate or sort of discover that enthesitis. This is a patient with sacroiliitis. This is a sort of more close-up view of sort of the irregularity of the joint here. And then also this whitening or sclerosis on the iliac side of the bone is a sort of classic radiographic finding with sacroiliitis. All right, so 48-year-old man complains of bilateral hand pain, minimal morning stiffness, but has pain with activity, especially during driving his boat on Lake Washington. His MCPs are particularly painful. His tenderness and swelling of the second, third, and fourth MCPs of both hands, and an x-ray of the right hand is shown. Next step for this patient, this is kind of a tricky one. NSAIDs and reassure, checks anti-CCP antibody, low-dose prednisone, or check ferritin. And the answer is in the picture. You guys are smart and have been studying. Okay, so here we want to check a ferritin. It might be nothing, but this patient has these sort of classic, we call them hooked osteophytes on the MCP joints. And that is something that is frequently seen in hemochromatosis. So we'd like to, find out if that patient has hemochromatosis. Here's a really good, angle where you can see that. Just look there. Okay, again, osteoarthritis, we saw this earlier. Frequently, osteoarthritis, it loves the first CMC joint. It just really loves that joint. It's one of the most frequent joints in the whole body where you can get osteoarthritis. And it can be painful and debilitating. And then also loves the DIP joints, which really, differentiates that from rheumatoid arthritis. Psoriatic arthritis can affect the DIPs, and osteoarthritis also tends to affect the PIPs as well, but not the MCPs. When somebody has MCP arthritis, then we think, do they have underlying inflammatory arthritis? Or maybe, maybe they were a boxer or something that predisposed them to destruction in that area. Classically, we see these nodes in rheumatoid arthritis, Bouchard's nodes and Heberton's nodes. They're painful often initially when they first pop up, but then over time, they generally are not painful. X-ray changes in osteoarthritis, obviously joint space narrowing. This is a patient with bone-on-bone knee arthritis. You often see a bit more whitening or sclerosis in the area of the osteoarthritis and sort of irregular contour of the bones and osteophytes. If someone with rheumatoid arthritis develops secondary osteoarthritis, generally what you see is kind of like a more even appearance of the osteoarthritis, like the whole joint is narrowed rather than medial or lateral. This is the medial aspect of the knee, which is the most common area of the knee to develop osteoarthritis in someone with primary osteoarthritis. These are secondary causes of osteoarthritis for you to review. And summary of prescriptions or potential things to consider for osteoarthritis. Rash and arthritis. So 30-year-old woman complains of 3 weeks of fever to 101 degrees, sore throat, lumps in the neck, joint pain in the hands, wrists, and knees, and an intermittent rash on the chest and extremities. She works as an elementary school teacher. So you see her, she's got tempo 100.8, pulse of 100. She has mild maculopapular rash on the chest, arms, legs, and large cervical lymph nodes. Bilaterally, swelling of the wrists and knees. She's got leukocytosis, mild anemia. Her liver enzymes are elevated. CRP is 200. So I'm worried about this patient. What would be the most useful next step? Do you want to check her ferritin? Do you want to send an ANA? Do you want to send Hep B? Do you want to send Parvo, IgM? Do you want to do all of these things? All right, so everybody wants to send Barbo. Everyone's very suspicious because she works in a school. Um, all right. So I probably just do all these things, right? Because like we're not really sure what's going on with this lady, but what you do want to get is think about getting a ferritin, and particularly in somebody with this combination of like high fevers, evanescent rash. So usually it's like a rash that's present when they have the fever and then it goes away. And if they have arthritis, and generally on labs you'll see leukocytosis, abnormal liver enzymes, high ferritin. It's a diagnosis of exclusion. So the ANA was an option there. Like this is a case where you want to send an ANA because you really want to confirm that the ANA is negative, rheumatoid factor anti-CCP, like this patient doesn't have those other diseases because there's no specific test for diagnosing adult onset Still's disease. These patients can get really sick if they develop macrophage activation syndrome. But we have some fairly good treatment for them now, often NSAIDs. IL-1 inhibitors are generally the best, but also IL-6 inhibitors like tocilizumab are very helpful. Very quickly, other sort of rash arthritis syndromes, gonococcal arthritis, which we're not seeing a lot right now, kind of ebbs and flows over time, but disseminated gonococcal arthritis patients, they come in with inflammatory arthritis and tenosynovitis. So think about somebody who has, remember, arthritis and tendinous involvement, skin lesions. They usually will have these little pustules, and classically, very few, maybe up to four, not a lot of these. And this is somebody that you want to swab all orifices for gonorrhea in order to make this diagnosis. Parvovirus, this kind of net-like rash on the face, arthralgia, potentially frank arthritis, sometimes with a positive rheumatoid factor, usually self-limited disease. Lyme disease, I'm going to skip over so that we can talk about myositis for a few minutes. So, myositis, clues. So patients will generally have they have weakness, right? They have muscle inflammation, and weakness really is the primary symptom. Occasionally, depending on the type of myositis, patients might have muscle pain, but typically it's going to be weakness that is like the trigger in your mind to say like, does this patient have myositis? They may have trouble getting up from a chair, climbing steps, lifting objects, head drop, difficulty swallowing due to weakness of smooth muscle, arthritis or arthralgia, Raynaud's, like this particular patient, they might have interstitial lung disease or rashes, which can be really important clues. This day and age, we are so fortunate that we have just in the last maybe 10 years really learned so much more about myositis specific antibodies. There are also myositis-associated antibodies. These antibodies can help with making a diagnosis, and they actually help identify sort of a clinical syndrome as well, and can also help us figure out how to stratify these people in terms of risk of malignancy, which is common, particularly in dermatomyositis. So, a 72-year-old man is evaluated for a 1 year history of increasing difficulty arising from a seated position, and more recently, he's had trouble with dropping objects. His medical history includes hypertension, hyperlipidemia, medications include atorvastatin and aspirin daily. On physical exam, vitals are normal, and he's found to have 4 out of 5 strength and bilateral quadricep muscles and some finger flexor weakness. Finger flexor weakness is important here. The rest of the physical exam is normal. The results of the laboratory test show that his CK is sort of somewhat mildly elevated to 890, which the following is the most likely diagnosis. Is it dermatomyositis, polymyositis, necrotizing autoimmune myositis, or inclusion body myositis? All right, good work, guys. You guys, the majority of you guys got it right. So it is inclusion body myositis. So these tend to be more of an insidious onset over years, and the key here really is that weakness of finger flexors. Patients will often have atrophy of the muscles, particularly the quadriceps, unfortunately leading to falls, dysphagia. Um, the biopsy can look kind of similar to polymyositis. And historically, a lot of these patients were sort of misdiagnosed as having polymyositis. We now have an antibody that can be sent to help identify these patients. And these are some photos of finger flexor weakness, quad atrophy. Unfortunately, that doesn't respond well to treatment. Also have polymyositis. This is subacute proximal myopathy, so shoulders and hips. Polymyositis, dermatomyositis, HMG-CoA reductase, immune-mediated necrotizing myositis. Those tend to be more proximal and subacute. So they can happen acutely, but generally subacute over a number of weeks. No rash in polymyositis. CK often quite elevated. And you can see polymyositis in combination with this antisynthetase syndrome, which we'll talk about. Again, many people with inclusion body myositis historically were misdiagnosed as polymyositis, but polymyositis is much more inflammatory and much higher CK, proximal weakness without the distal weakness, and remember subacute rather than chronic. I'm going to skip through this one. So that refers to the antisynthetase syndrome. So people with myositis, dermatomyositis, or polymyositis phenotype can have something called antisynthetase syndrome. They have particular antibodies, and they have 3 out of 5 of arthritis, mechanics hands, which is this scaling along the fingertips, interstitial lung disease, Raynaud's, and myositis. Dermatomyositis, again, subacute proximal weakness and generally high CK. Not always. They can present without muscle involvement initially. And these patients, they classically will have findings on their skin, particularly the hands. Like the hands are, look to the hands when you were thinking of dermatomyositis. I've only seen one dermatomyositis patient ever who didn't have something on her hands. So these are Gottron's papules. They can be papular or even flat. They like to occur over the knuckles. So the MCPs or PIPs, occasionally DIPs. Look carefully at their cuticles. These are called raggedy cuticles. They're sort of overgrown and disrupted. Some hemosiderin deposition and frankly dilated mouthful capillaries in this patient. This is a patient with heliotrope rash, that kind of sort of purple rash overlying the eyelids. And dermatomyositis in general really is more purple than red. So when you see that purple hue and a classic distribution, heliotrope rash, Shaw sign, Gottron's papules, Gottron sign, and a Holster sign. This is on the lateral thigh. And we don't know why this happens really, because much of the dermato is photo-induced. So in setting of sun exposure, and this is not a frequent area that is exposed to the sun. So, um, and then this question is referring to HMG-CoA receptor immune-mediated necrotizing myositis or necrotizing myopathy. This is something, again, that we discovered fairly recently. A certain percent of patients who take statins will have this autoimmune syndrome induced. They will develop antibodies against their statin, and they develop actually a horrible myopathy. These patients can have some muscle pain. They generally have that proximal weakness and very high CK, and it continues despite discontinuing the statin. And we're generally treating them the same as we would patients with dermatomyositis and polymyositis. And with that, I'm going to leave the rest of these for review. I'm going to stop sharing. And I made it essentially to the end of the presentation. Now my computer is not wanting to participate, but we have an answer key here at the end for all of those questions that we went through. And you guys did so amazing on all of those questions. So well done. Clearly, you've all studied so much already. I'm going to let Dr. Bay share, and thank you all so much.
Thanks so much to Jenna. Let me. Okay. Hopefully everyone can see and hear okay. Just interrupt and let me know if you are not able to. I'm Allison Bays. This is kind of volume 2 of all of rheumatology that you need to know. So we're going to go over these topics: rheumatoid arthritis, psoriatic arthritis, crystalline systemic sclerosis, and vasculitis. I speak pretty quickly, but hopefully the slides are clear enough where you'll be able to kind of review some of these things on your own. And there's a few additional practice questions at the end. Um, so rheumatoid arthritis, an inflammatory polyarthritis that affects women more than men, and we tend to see a lot of morning stiffness. Dr. Thompson talked about kind of the differences in different types of joint pain and stiffness. And with rheumatoid arthritis, we tend to see the patterns of the MCPs here in green, the PIPs in yellow, and especially the wrists as well. Those are the primary places where we see rheumatoid arthritis in the hands, at least. So it has that pattern. The lab tests, we always want to check rheumatoid factor and CCP, which is also called ACPA in some situations, and inflammatory markers as well, though those are not always elevated. We also, when suspecting rheumatoid arthritis and other inflammatory arthritides, we want to get some x-rays. And then the main things that we're going to look for are these early changes if it's early in the diagnosis. So the very first thing you might see is osteopenia, so kind of these lighter colors around the joints, the lighter color of the bones, and then marginal erosions or changes right at the sides of the joint. So we'll see some examples of those. This is an example of early rheumatoid arthritis. And what we can see, especially here, just even looking, is this right third and fourth PIP that are swollen. You can see the kind of lack of definition in the lines in those joints. This is really progressive RA, so you can see that the fingers are kind of starting to slip beneath the MCPs, so there's some subluxation. You can see a little bit of ulnar deviation with the fingers kind of pointing out to the ulnar side. And you can see just how you're not going to be able to see the peaks and valleys. You see that kind of swelling. So this is not only progressive rheumatoid arthritis, but it looks a little active as well. It can also affect the feet. And I will say sometimes the symptoms can start in the feet as well. So that's something to kind of know as well when you're initially seeing someone.
And
And
Dr.
I like this.
Bays, I'm sorry to interrupt.
Uh-huh.
It looks like there's a visual glitch where the slides are cutting back to your intro slide as well. I'm wondering if there's another window that you could minimize for that.
Okay, let's see. Um, continue. Another window.
Because it's showing the non-presenter view intermittently. It like
Oh,
flashes
weird.
between that and your actual current
Okay, let's see.
slide.
I closed all of the other
Great.
slides. Continue to share. Okay. What about now as I
Ooh,
advance?
that looks perfect. Thank you.
Okay, perfect. Yeah. I don't know. Maybe there was something else interfering. Thank you for letting me know. So I like the picture on the right because not only does it show advanced arthritis, but it can kind of show you an example of active arthritis. So on this left hand, you can see how kind of puffy those MCPs are without the normal peaks and valleys, whereas you can see them on the right. So this hand on the left looks a little more active than the one on the right. And then in terms of the lab, so we have the rheumatoid factor and CCP. The rheumatoid factor is about 80% sensitive and specific, whereas the anti-CCP or ACPA is more specific. And so usually what we'll do is we'll get both of those when we're evaluating someone for rheumatoid arthritis. And here are some changes in rheumatoid arthritis over time. So if you look over here, what you'll see is a little bit of periarticular osteopenia. So you'll see this kind of lighter color of the bone right around the joint. And then this is an example over here of a marginal erosion. So it's right at the margin of the joint, and there's a little kind of bite out of the bone. And if you look across, you're seeing that the joints really get worse over time. So you're seeing larger erosions, especially in these two joints over here. And then in the last image, you're seeing kind of subluxations as well. So very destructive over time if not treated. Um, so in general, we would say for treatment principles of rheumatoid arthritis, we want to recognize early, and then treat to target. And we do have targets that I'm not really going to go into, but we kind of give the rheumatoid arthritis a score and we try to get people in remission. And so we want to be very aggressive if people present early with aggressive features. So erosions at presentation, extra articular features, which we'll talk more about. So scleritis, interstitial lung disease, rheumatoid nodules. We treat more aggressively if there are a large number of joints involved. Methotrexate is really an anchor medication, a first medication that we try, and we often combine it with other medications as well. And then we do routine disease activity monitoring as well. These are some of these are the new treatments for, or these are the treatments for rheumatoid arthritis kind of separated out by their mechanism. And then also in parentheses is their the year of their FDA approval. And so we usually start with the conventional DMARDs. Methotrexate is really the workhorse of those. And then sometimes we'll combine with the other medications, hydroxychloroquine and sulfasalazine. I would say typically the next one we'll jump to, unless there are any reasons not to, would be the anti-TNF agents. And usually we'll kind of try one or two of those before moving on. And then we have a whole host of other medications and classes as well. We have an anti-B cell agent, rituximab, T cell, abatacept, two IL-6 receptors, and three JAK inhibitors. And recently, last year, vagus nerve stimulation was also FDA approved for rheumatoid arthritis. And I would say personally, I haven't used that much, and we're still kind of getting set up to offer it at our institution, but good to know about. Really, when we're treating people, we think about their contraindications. So methotrexate and leflunomide both can affect the liver, so we avoid those in liver dysfunction. Methotrexate can accumulate when someone has kidney dysfunction, so we don't give it in renal dysfunction. Neither are good in pregnancy. In terms of the TNF inhibitors, it's thought that the TNF medications can exacerbate or cause CHF. So I would say we still use it, but are very cautious and potentially only in conjunction with someone's cardiologist and if they're stable. Active TB is kind of an absolute contraindication. Latent TB, which I see a lot, usually we treat for at least a month before starting the TNF inhibitors because it's known to kind of convert latent TB to active TB. Abatacept, we caution with COPD. Tocilizumab, we do not give with diverticulitis because it can cause bowel perforation. Hepatitis B can reactivate, especially if it's core positive when using rituximab. So that's something we're also very cautious about. We sometimes still do it, but we'll offer some medications to suppress the hepatitis. JAK inhibitors are a little tricky. We usually use them in younger patients that don't have as many risk factors for cardiac disease or thrombosis because they have black box warnings. Okay, I'm going to give you a chance to kind of read this case and then go ahead and answer the question. I'll give you a minute to do that. Okay, great. So most of you chose the correct answer, which was to give IV folinic acid. And the reason for this is most likely going to be because of the methotrexate. And so this methotrexate has accumulated, and some of the side effects are oral ulcers, nausea, vomiting. And this could be because the patient had a diarrheal illness, for example, and they were underhydrated because the BUN and the creatinine are both high, but it can cause lower white blood cell counts, nausea, vomiting, oral ulcers. And so, most likely this patient needs a lot of fluids, but then IV folinic acid can also reverse the side effects of the methotrexate. So in terms of the important medication side effects, so I know you talked a bit about hydroxychloroquine with Lupus as well. So that's another medication that we also use in rheumatoid arthritis. Sulfasalazine is another kind of mild additional medication that we use, which I would say the majority of the mild side effects includes the rash, but you can get agranulocytosis. Um, Methotrexate very commonly causes some elevated liver enzymes, but can cause bone marrow suppression. We talked about the TNF inhibitors. In terms of the TB reactivation, TNF inhibitors, unfortunately, even though they treat psoriasis and psoriatic arthritis, can also cause psoriasis, which can be confusing. And then drug-induced lupus, which Dr. Thomason had mentioned. And then the JAK inhibitors, I would say that I really am cautious with because there are black box warnings, heart-related events, and we really worry about blood clots as well. So we tend not to use those in our patients with underlying cardiovascular disease. All right, here's another question. I'm going to let you go ahead and read and answer this one. Okay, great. Let's see. I think everyone got this one correct. So the answer is a higher resolution CT of the chest. So let's go through why that might be. So this is a patient with rheumatoid arthritis having dyspnea. So we're going to talk about some of the extra-articular diseases. So something we worry a lot about is rheumatoid arthritis, interstitial lung disease. You can have nodules, but you can also have interstitial lung disease. You can, sorry for the difficult picture, but you can have scleritis and scleromalacia. The two of the main causes of scleritis are the vasculitis, GPA, which we'll talk about, and rheumatoid arthritis. And then you can have rheumatoid nodules, which often occur at the extremities. The elbow is a really common place, and you can get them in the lungs as well. So in terms of ILD, so this happens in a fair number of RA patients, male more than female, often after a few years of disease, and more likely in patients who have positive rheumatoid factor CCP and higher titer rheumatoid factor and CCP. You can get UIP or NSIP, UIP being more common. And then in terms of treatment, you can use steroids. Mycophenolate is very common. Rituximab is also very common for ILD, and then there are antifibrotics as well. This is second only to cardiac disease in terms of mortality increase in rheumatoid arthritis. It's also well known that rheumatoid arthritis patients have a higher risk of cardiac disease. And then also you can get ILD-associated pulmonary hypertension as well. And the UIP pattern has the highest mortality. Some other complications that we don't tend to see quite as much, but you can still see Felty syndrome. So you can get some leukopenia, splenomegaly. I have probably only seen that, I think, just twice in my career. So it's not very often. C1, C2 subluxation. So you can get neck pain and myelopathy. This is really important to evaluate before any procedure. So if someone has very long-standing rheumatoid arthritis and they're going to get intubated, for example, it's very important to kind of start off with an x-ray and then do further investigations to make sure they're not at risk for injury when getting intubated. Septic arthritis, rheumatoid arthritis patients are more at risk for septic arthritis because of the changes in their joints. Tendon ruptures, I see that a lot, unfortunately, but usually in people who have very kind of long-standing disease who are not controlled for many reasons. But over here, this is an example of tendon rupture. And so this person cannot fully extend their fourth and fifth digits. Rheumatoid vasculitis is pretty rare, but you can see it can present like a polyarteritis nodosa, which we'll talk about. You can get foot drop, wrist drop, skin ulcers as well. Okay, immune checkpoint inhibitors. I'm not going to go into a lot of detail on this. I'll probably just leave this as a reference slide, but I will say that this kind of goes in the rheumatoid arthritis section just because we do see a lot of inflammatory arthritis as a complication for immune checkpoint inhibitors used for various cancers. So I put just kind of the general different types of immune checkpoint inhibitors and some of the common autoimmune complications. Okay, here's another case with an x-ray. I'm going to have you take a look at that x-ray and answer the question. All right, so most of you also got this one correct. And so this is called a pencil and cup deformity. And so the primary one we're talking about is over here. So over here on the thumb. And so this is kind of the cup area and the pencil is going into it. And this is the pencil and cup deformity is associated with psoriatic arthritis. So going on to psoriatic arthritis tends to affect the PIPs in yellow and the DIPs in blue, but not always. There are different types of disease, and so there are five main types of psoriatic arthritis. So you can get a hugely variable presentation, and also it can be mild, but it can also be much more destructive even than rheumatoid arthritis, depending on the situation. So you can get a few joints involved or multiple joints involved. You can get the DIP involvement, the blue area. You can get arthritis mutilans, which you kind of get the telescoping of the joint, and you can also get more of a spondyloarthritis picture. And a little bit more unique to psoriatic arthritis is the enthesopathy or sausage digit. So here's some examples. So over here, I would say this is dactylitis. You can see that it's more fusiform, so the whole finger. You can definitely see that the PIP on the second digit is swollen, and you can get a little bit of loss of that architecture, but you also see that kind of the whole digit is a little bit more swollen. And then over here on the left, you're seeing some of the arthritis mutilans, especially in the little pinkies, where you're just kind of getting collapse, and that can be incredibly destructive. Another thing that we might look for on exam is this nail pitting. And so that's very common in psoriatic arthritis as well. And so that's something we always look for on exam. And then I would say another important place to look for psoriasis is in the scalp and also in the ears. You can also get it in the belly button and the gluteal cleft. So, when people are presenting with psoriasis and psoriatic arthritis, sometimes the psoriatic arthritis can come first before the psoriasis. And also sometimes people have psoriasis, but it can be very mild. The diseases aren't necessarily both severe or both mild. So sometimes you have to go hunting a little bit for the psoriasis. The initial treatment is similar to rheumatoid arthritis, so methotrexate, sulfasalazine. We don't really use hydroxychloroquine. It's thought to not improve psoriasis and maybe worsen it. We use the TNF inhibitors a lot. And something to note is that steroids may help peripheral arthritis, but as you taper, it can cause a flare of the psoriasis. So we tend not to do a ton of steroids unless the arthritis is really bad, because we do risk flaring the psoriasis. So, good news for our patients, maybe bad news for your studying, is that there are a lot of medications that are FDA approved for psoriatic arthritis, which I think is great. Since we already kind of talked about the TNF inhibitors, I kind of collapsed them into one. But we have the IL-17 inhibitors, I would say. So Cosentyx is the one that's been around the longest, and bimekizumab was approved in 2024. We have the IL-23 inhibitors. We have the JAK inhibitors as well. And then we also have kind of newer, and then I would say the ones where we differ, we don't really use IL-17 or IL-23 for rheumatoid arthritis. JAK inhibitors we can use for both, which is great. Apremilast is a PDE4 inhibitor and is an oral pill, which is great. not super effective, but that's a great one that we can combine with other medications. We have abatacept or Orencia, which we also use for rheumatoid arthritis. And then we have a brand new approval for deucravacitinib this year, which is the first in its category, a TYK2, which is kind of upstream of the JAK inhibitors, and it's also oral. So that's really exciting to have more oral options because we have so many people who, at least the people that I see, we treat a lot of people who have difficulty, getting or storing medications or people who are fearful of needles. So it's great to have some oral options. Okay, another question for you that I'll let you read and answer. Okay, so it looks like we're getting close to done. It looks like most of you got the correct answer and nobody chose D, which was just for fun. But this is keratoderma blenneragicum, and the reason is because it's associated with the GI illness and also involves eye pain and redness, joint pain. So that's why it's different from just the palmopustular psoriasis. So here are some yeah, I had improved. I forgot to take out the old slide, but I was improving the new slide on the old slide. So this is the one that I like a little better. This is reactive arthritis. Here are some pictures of reactive arthritis. You can see over here to the enthesitis compared to the normal heel as well. So you can see that swelling. And then you can see the keratoderma blenneragicum as well. And then also, we always have the can't see, can't pee, can't climb a tree, way to remember, the conjunctivitis, urethritis, and arthritis, but not everybody has that full triad. It tends to follow a GI illness, and you get usually a few larger joints involved, and it may not be symmetric, unlike some of our other diseases. And interestingly, we often see HLA-B27 positive. Dr. Thomason mentioned this with ankylosing spondylitis. And in those situations, sometimes the reaction is more severe and chronic. And then this is just the workup and treatment. We're looking for anything that we can treat. Most of these resolve on their own, but some ultimately do need some treatment, in which case we may use sulfasalazine, methotrexate, or even a TNF inhibitor. Okay, I think what we're going to do, actually, I'm going to skip some of the questions just so we have enough time to go through everything. So I'm going to start talking about crystalline arthritis. There are also some questions at the end that you can also work on your own. So here are some images for CPPD. And so interestingly, it tends to be very subtle. So here on the knee, you can see kind of that white linear changes in the joint. And so that's what we call chondrocalcinosis. Now, that's not definitive. Really, what's definitive is you do an aspiration and see you look at the fluid under the microscope. And then here we have some more chondrocalcinosis in the wrist. And then the CPPD loves the wrist and the knee. So that's a very common place for it. So in terms of CPPD, you get these calcium crystals that can cause this NLRP3 kind of inflammasome inflammation, typically at the wrist and the knee. Kind of sounds like inflammatory arthritis. So a lot of times, well, it is an inflammatory arthritis, but when we're diagnosing someone, we're also thinking about rheumatoid arthritis because they sound very similar. And so, often comes with morning stiffness, swelling. But when you aspirate, you may see these kind of rhomboid-shaped crystals, positively birefringent, and they are harder to see under the microscope than gout crystals. And so sometimes you have to search a little bit more. One important thing is Crown-Dunn syndrome. So you can get this calcium around the odontoid. And so sometimes people get this acute neck pain, fever, and elevated CRP. And then the differential, you're thinking about meningitis, giant cell arteritis, polymyalgia rheumatica, something septic. And so you diagnose with imaging. And then there are some secondary causes to think about. And then the other thing is that nothing really dissolves the calcium crystals. And so often what we're doing long term is giving people colchicine or giving them IL-1 inhibitors to help control the inflammation. Okay, we're going to keep going through this question, but you can take a look on it, take a look at it on your own. This is gout. So the other main crystalline arthritis, typically in men over 40, and rare in women in premenopause. The first MTP is typically involved at some point. When you're checking the uric acid, know that that can often decrease during attacks. So when you're diagnosing it, you also want to aspirate and look at the crystals under a microscope. And then they tend to be needle shaped and strongly birefringent. I feel, at least in rheumatology, it's often a test question. So for gout, they tend to be yellow and parallel to the polarizer. And so you can kind of remember all these double L's. Of course, allopurinol doesn't have anything to do with it when you're looking under a microscope, but allopurinol we always think of, rightfully so, as related to gout. So that's a way to remember it. In terms of treatment of acute gout, so we have NSAIDs, we have oral prednisone, intra-articular steroids. So that's if infection is ruled out. You can do colchicine acutely, but especially if it's been going on for a while, then that's not usually going to solve the problem, especially if it's multiple joints. Typically in our institution, we use anakinra and IL-1 inhibitor a lot, but that's not FDA approved. And then there's another IL-1 inhibitor, canakinumab, which is approved and can be used every 3 months when patients are unable to take other medications. In terms of urate lowering therapy, so we have our typical allopurinol and febuxostat, the xanthine oxidase inhibitors. I think one of the main things to know for allopurinol is to consider checking HLA-B5801. So that particularly in Han Chinese, Thai patients, Black patients are more likely to have HLA-B5801, and that can cause Stevens-Johnson syndrome if they take allopurinol. And then febuxostat, we also use very commonly. We typically start with allopurinol. Probenecid, we often don't use as much in rheumatology. Often, people may have some renal dysfunction, and we don't use that one with lower renal dysfunction. And pegloticase, I will say, is a great medication, but extremely expensive, very difficult, every 2 weeks infusions. And so that's something we don't typically use very often, but it's good to have as a possibility. So I'll let you look back at the details of some of these things. In terms of prophylaxis, so in rheumatology, whenever we're starting someone on a urate lowering therapy, we do prophylaxis for usually about 6 months after the last flare or the last change in their urate lowering therapy, because as uric acid shifts for different reasons. So say someone's in the hospital for CHF and they're getting a bunch of diuretics, you're going to get uric acid shifts and a higher risk of gout. Other situations, like if you stop your allopurinol suddenly and restart it suddenly, you're going to get more likely to have flares. And so with this, we usually try to do some type of prophylaxis. So that can be colchicine. That's what we like to do most typically. NSAIDs are difficult because so many patients with gout cannot take NSAIDs. We hate prednisone for long term because, Dr. Thomason talked about it as well. We love and hate prednisone for long term because this is more of a long term thing, the prophylaxis, until we get things under control. And in a way, the canakinumab is really for acute flares, but you can also kind of consider that as potentially as a prophylaxis as well. we always want to modify risk factors. You can send people to nutrition to kind of discuss diet, avoid medications. So some medications raise uric acid. Losartan lowers uric acid. Vitamin C also can be very helpful for uric acid as well. That's the oranges. Okay, so here is another question that we are going to skip through. I would say colchicine and gout is a difficult thing because sometimes people have renal impairment, and that's really the biggest risk because it can accumulate when you have renal impairment. And so we usually either use a very reduced dose or try to avoid it in renal dysfunction. And there's also, I think it's good to know because we use colchicine for a lot of other things as well. And so colchicine and gout, but this can also apply to, we talked about it for pseudogout as well. But you can get weakness and elevated CK. And I would say the earliest thing, but not always, is you can get a lot of diarrhea. There are things that compound the risks, like other medications as well. So that's something to know, and I think very, potentially very testable. Here's some tophi. I know most of you, all of you have probably seen these, but you get lumps and bumps, often get that kind of whitish change, or sometimes even extrude some of the uric acid. Uric acid is actually radiolucent, and so it's not typically darker on the x-rays, but it can have calcium depositions, which you can see, and then you can get large erosions, and those tend to be, look more like a bite out of an apple over here. They tend to be kind of larger and bulkier than the changes with rheumatoid arthritis, and then sometimes more away from the joint as well. Okay, so two more topics. We're going to do systemic sclerosis and giant cell arteritis. So systemic sclerosis, the peak onset is usually about 45 to 60, more common in women. And when you're talking to someone about the history, you're asking about reflux, you're asking about calcinosis that they may have experienced, tightened skin, especially around the mouth and fingers, and then telangiectasias. So interestingly, the telangiectasias of scleroderma are often a little different. So as you can see here on this woman, they're not like the spider ones that you might see with liver disease or alcohol, but they're more boxcar, so square or rectangular. Most everyone should have ANA positivity. And then the main antibodies we're looking for are the centromere, which can also be a pattern as well. So sometimes on the ANA, it'll say centromere pattern, and that's really enough as well. You get the SCL70 and the RNA polymerase 3. And this is Raynaud syndrome. So I think important to kind of distinguish primary and secondary. So primary tends to be kind of longstanding, runs in families, and doesn't tend to be as severe with kind of ulcerations on the fingertips. The definition is really you kind of get this whitish color, then more purple, then it kind of turns red when rewarming. It can be quite dramatic. And then the secondary we think of as associated with autoimmune disease. And we look at the fingernail bed and look at the capillary nail folds. So it should be very normal, straight. But then what we're seeing often in autoimmune disease is you get kind of irregular capillary nail folds. You can get dropout, so kind of areas where they're missing, or infarcts. And so that's often associated with our diseases, especially scleroderma, dermatomyositis, and lupus. Actually, this one, let's see, why don't we do this question? I think this is a good one. So I'll have you guys read this and answer. Okay, great. So there's a bit of a spread, but most of you got this one right. The reason why I think this one is important and very testable is this is something that can be very dramatic. Someone can actually lose their kidneys. There's a higher mortality rate, but we actually can fix it. So I think this is a very testable question, and I'm glad most of you uh, ended up getting it right. Scleroderma renal crisis. So this is something that we always have to think about. So if there's new onset hypertension, new renal failure, hemolytic anemia, that's when we want to be thinking about it. And of course, in someone who has scleroderma, you may find schistocytes on blood smear. And then the risk factors include a rapidly progressive or diffuse scleroderma and steroid use. So this is one of the situations where in someone who has scleroderma or bad scleroderma, you really do want to avoid steroids because that can precipitate a scleroderma renal crisis. And then it typically tends to occur in patients who are RNA polymerase 3 positive. So the treatment is actually ACE inhibitors. So captopril is the most used because often we're treating in in the ICU, and then it's titratable. Unfortunately, using ACE inhibitors prophylactically does not help prevent scleroderma renal crisis. I wish it did. That would be great. Morbidity and mortality are high, many requiring dialysis. So this is something we don't see very often, but it's very important to recognize. The patterns of disease can be limited or more diffuse, and here are some of the associations and what the diseases you may see with scleroderma and their associated antibodies. And so sometimes people may have pulmonary hypertension, interstitial lung disease, anti-RNA polymerase 3, and then sometimes we also see pericardial effusions or conduction abnormalities. And then over here we see this is kind of more severe sclerodactyly, and so you can see the kind of thickening and changes in the fingertips over there, and then of course Raynaud's. And this is a picture of the gastric antral changes that you might see, also called kind of watermelon stomach. Um, so I will say still, most of the treatments for scleroderma are going to be supportive treatments. We don't have one medication that we give to all scleroderma patients, but rituximab is approved for ILD, which is great. In scleroderma specifically. So that is, at least we have a treatment for that. And then I know Dr. Thomason mentioned the CAR T as well. And so that's hopefully a very promising treatment for scleroderma as well, because we don't necessarily have a lot of treatments. And I'm not going to spend time on this. Eosinophilic fasciitis is just a mimicker of scleroderma and important to know. And then let's get to vasculitis. So we have a little bit of time, so I'll just try to hit most of the important points, and there's some reference slides in here as well. I will say the way that we really think about vasculitis is in terms of vessel size. So for large vessel vasculitis, we think about giant cell arteritis, Takayasu's arteritis. For medium vessels, polyarteritis nodosa. And then really we have a ton of vasculitis in the small vessel vasculitis. So we have our ANCA vasculitis, MPA, GPA, and EGPA. And then we have our kind of immune complex mediated vasculitis as well. And then Behçet's here at the bottom can affect any vascular bed. I'll let you kind of go through those on your own. In terms of the manifestations, they tend to follow vessel size, which is great. And so small vessel vasculitis tends to affect the smallest vessels. So those are in the skin, you get palpable purpura, in the lungs where you might get diffuse alveolar hemorrhage. In the eyes where you might get scleritis, mononeuritis multiplex, so the small blood vessels feeding the nerves, and then the small blood vessels feeding the kidneys, which can cause glomerulonephritis. The vascular beds can, of course, you can get some small vessel vasculitis features in medium and large, that can mix a little bit, but tends to follow this pattern. So for medium vessel vasculitis, which is mostly polyarteritis nodosa, you can get skin nodules and ulcers. You can get livedo reticularis, gangrene of the digits. You can also get mononeuritis multiplex, inflammation in the eyes, and testicular pain, which is interesting because there are not too many things that cause testicular pain. So if you have a patient that you're evaluating that has testicles, you can ask if they've had testicular pain, and that may be a clue to the underlying diagnosis. In terms of large vessel vasculitis, you can get limb claudication, asymmetric blood pressures. Those are more typical with Takayasu's, as well as loss of pulse. You may get bruits, more typical in Takayasu's, but you can also get it in giant cell arteritis. And then, of course, the feared visual loss in giant cell arteritis. Um, in terms of this is definitely more of a reference slide. It's very busy. But what I wanted to do is kind of break down the different main types of vasculitis and then what it affects. And the things in bold are what you're going to see typically on the test. And it's also, one thing I think it's important to recognize too, like if you look at microscopic polyangiitis, there are not a lot of things that differentiate it from the other ones. Like you don't have all of the clinical signs with giant cell or granulomatosis with polyangiitis. So all of the otitis media, sinusitis, but that's also a clue, right? So usually if you have granulomatosis with polyangiitis, you're going to get those in the stem. With EGPA, you're going to get something involving eosinophils. Hepatitis C, very important to note that it can cryoglobulinemia can be associated with hepatitis. And then IgA, you can get deposition in the skin and the kidneys. Here are some pictures of what you might see. This is typically with granulomatosis with polyangiitis. Also granulomatosis with polyangiitis, nodular scleritis. So you can see that the scleritis you see with rheumatoid arthritis and giant cell granulomatosis with polyangiitis. Wrist drop, you can see with any of our small vessel vasculitides, and then the cavitary lung lesions end up typically being GPA granulomatosis with polyangiitis. Um, Palpable purpura. So I wanted to make a separate mention of that because it can occur with our small vessel vasculitides, but it can also occur on its own. There's a handful of situations where I didn't find a cause, but it can be associated with medications. It can be associated with malignancy, infections. So typically you want to treat the underlying disorder. So if you see palpable purpura, you should always think about vasculitis, but just keep an open mind. This is a lab testing that we do with small vessel vasculitis. So we can see elevated inflammatory markers. We might see some leukocytosis. Typically, complements are normal, except for C4, which might be low with cryoglobulonemic vasculitis. And the cryoglobulins, it is important that it needs to be collected at room temperature so it doesn't precipitate out. These are the associations. So the C-ANCA maps to the antigen PR3, the P-ANCA maps to the antigen MPO in microscopic polyangiitis. It's hard to remember this. Literally everybody struggles. So I did come up with a mnemonic that kind of ties those things together for GPA, and then you can just remember the other one is the other one. So if you can just remember that GPA, PR3, and C-ANCA kind of go together, then you can remember that the microscopic polyangiitis is the other one. And there are some crossovers, but I think those are less likely to be tested. These are some other things that we want to do when we're thinking about vasculitis. So you want to do some chest imaging, look at your analysis, rule out infection, and always rule out drugs with the tox screen. There are a lot of mimickers. Treatment. Typically, we treat depending on the severity. So if it's kind of limited sinus disease, you might do methotrexate. If it's really organ-threatened disease, you're going to do high doses of solumedrol, rituximab or cyclophosphamide. We tend to mostly do rituximab these days because of the less side effects that you might see with the cyclophosphamide. Avacopan was approved in 2021 to kind of reduce steroids, but actually this year it's likely going to be removed from the market. There are issues with not only with the clinical trial, but this concern for vanishing bile duct syndrome. So you're unlikely to see that, and it's likely going away. Let's see. So we're just about out of time. I think we're at the end of the slides. I'll just go through and make a few more points. For subacute bacterial endocarditis, this is almost a perfect mimicker of small vessel vasculitis. So if you're thinking about small vessel vasculitis, you're going to also want to be ruling out endocarditis. And I've seen that a number of times. PAN. So this is primarily associated with hepatitis B and tends to be more of a medium artery. I would say the 2 points is that it tends to spare the lungs. The renal biopsy is non-specific typically, and you do get a lot of skin changes in terms of nodules, ulcers, and gangrene. So I'll kind of give you some of the pictures there for PAN. And then we'll wrap up with giant cell arteritis. So the age is over 50 for giant cell arteritis, but typically this is going to be someone in their 70s, often their 80s, women more than men, and there's a significant overlap with polymyalgia rheumatica. So most commonly, people are going to get a new temporal headache, scalp tenderness, and maybe temporal artery that's abnormal. These are popping out. They're likely very tender. It's not always like that. I mean, occasionally you'll have a patient say like, "Oh, I had a snake on my head." That's great. That's helpful, but it's not always going to be like that. Jaw or tongue claudication is a common symptom. The biggest thing is the vision loss is an emergency, typically doesn't come back, typically due to anterior ischemic optic neuropathy. And so if there's any stem that has vision concerns with GCA, the answer is going to be to give steroids immediately. You don't wait. So often people will have elevated inflammatory markers. If they're normal, it doesn't completely rule it out, but is unusual to have normal inflammatory markers with giant cell arteritis. This is the classification criteria. It's not, similar to the ones Dr. Thomason had discussed. It's not diagnostic, but this is important. This is what we consider important in GCA. So the main points of GCA, again, don't delay steroids. I would say that there's some controversy over temporal artery biopsy and ultrasound. We do a lot of ultrasound at my institution, but in the US, the temporal artery biopsy is recommended over the ultrasound because of differences in operator abilities. So we do, in the US, we typically still want to get a temporal artery biopsy. You want to get a longer segment if you can, typically over 1 centimeters, often over 2, but there are skip lesions. And so a normal temporal artery biopsy is invasive and also doesn't rule out giant cell arteritis, which is a little difficult. And so the treatment, so we start, even if there's no vision changes, we'll start with oral prednisone. If there's a suggestion of vision changes, then the patient goes to the ER, they get IV steroids. We have two main steroid-sparing agents. So the typical one is tocilizumab that was approved back in 2017. We use that a lot. We actually did get upadacitinib approved last year, which is an oral JAK inhibitor. And they didn't find the same concerns that we see in rheumatoid arthritis with the kind of cardiovascular concerns and the blood clots. But I will say I'm still very hesitant because these patients are quite a bit older and tend to have a lot of cardiovascular disease. So I'm still hesitant to prescribe it just personally. There's a little bit about aortitis, Takayasu's as well. I think what we should do is wrap up. I'm just going to give kind of a one-liner and then you guys can look at it on your own. I would say Behçet's disease can affect any vessel size and comes with oral ulcers. We have some treatment options. Relapsing polychondritis typically affects the ear and the bridge of the nose and can be associated with many other things as well. IgG4 related disease has a lot of clinical signs and symptoms. We need a biopsy to diagnose. And there's a new medication approved last year, inebilizumab, which we're using, which is great. So I have a slide with some of the most testable points. So, I think it's a great thing to kind of run through these before you take the test. And then at the end of the slide set, I also have a few, I know I did skip a lot of questions going through, but so you can go through those. And then there are a few kind of at the end as well. And of course, the feedback that you're giving to the program is the most important. But if you do get a second to do a teaching eval for my own job, that would be great as well if you have time. And I think that's about it. It should be your break time and good luck.
Great. Thank you so much, Dr. Bays.